Hello, everyone. I'm Dr. Yuval Baruch. Um, this is a talk by myself and Dr. Jeffrey Goldstein, meant for residents at NYU as a preparation for their boards. We're going to talk about degenerative lumbar spine disease. The goals of the talk is for you to be able to clearly create a differential diagnosis based on the history and physical exam, to understand different exam findings and imaging studies, to be able to perform diagnosis and propose treatment options for the common degenerative lumbar conditions based on the most relevant studies, and also to understand what are the indications for different surgical options for these conditions. The key points we're going to discuss today is the clinical relevant surgical anatomy, meaning anatomy from a surgeon's perspective. We're going to talk about diagnosis and treatment of low back pain, of lumbar disc herniations and radiculopathy. We're going to talk about lumbar spinal stenosis and also about adult ischemic and degenerative spondy. Like always, we're going to start with the clinical anatomy. On the left, we're seeing a posterior image of the spine. On the right, the anterior. On the left, we see a surgeon's perspective from the posterior approach. On the left, we're seeing the longissimus and iliacostalis, and between both is the Wiltse approach. Deep to them or anterior to them is the multifidus, and then the TPs and facets. On the right of that image, we're seeing the bony anatomy, and in color is the different aspects of the bony interface. The yellow is the spinous process, which is also the most posterior aspect of the bony vertebrae. The orange is the lamina. As you can see, the lamina has a cranial and a caudal interface. The caudal is where the ligamentum flavum is attached. When we go more to the right, we can see that every bony element in the vertebrae has two articular processes. We have the superior and the inferior, which are both adjoining to create the facets. Between both articular facets, we see the pars interarticularis, which is painted in pink. The blue is the transverse process. Between both transverse process and lateral to the pars is the nerve root where it exits the foramen. On the anterior aspect of the spine, we're seeing the ALL, the psoas muscle, the discs, and the nerve roots, which also exits between every TP and goes ventral. When we talk about relevant roots and dermatomes, I find it easy to use the left picture, to understand how different disc herniations create different symptoms. We have two of the most common, well, let's say two of the three most common disc herniations. I'm not showing the central, which is going to compress the canal centrally. I'm talking the paracentral disc and the far lateral disc. You can see here that the paracentral disc will mostly influence or compress the traversing nerve root, the root that is going down and going to exit below the next pedicle. So if a L4-5 paracentral disc will compress the traversing L5 nerve root, and it will create symptoms in the L5, which is the long toe extensors and the lateral leg. The far lateral disc in the L4 disc space will mostly compress the exiting nerve root. The nerve root, which is already exited below the L4 pedicle, will create L4 radicular symptoms. This is the ASIA scoring part of the lumbar spine. And we can see usually we take the L2 for the hip flexors, the L3 for the knee extensors, and the knee jerk reflex or the quad reflex, so the patellar tendon reflex, L4 for ankle dorsiflexion or drop foot, L5 for the long toe extensor, first big toe, S1 for ankle plantar flexors and the gastrocnemius or Achilles tendon reflex. When we're talking about dermatomes, there's different pictures in different anatomical atlases. Usually L1 is the groin, The L2 is the anterior thigh, L3 is lateral thigh and knee, L4 is the anterior shin, L5 lateral, and S1 is the bottom of the foot, the plantar aspect of the foot in the first web space. The nerve roots are arranged in a very specific way inside the cauda, meaning that the nerve root that is going to exit is going to be most ventral and most lateral. So we're talking of the L3 for this space. The L4 nerve root is going to exit, and it is in the most lateral and ventral part of the cauda. The S2, S5 are usually posterior and central. This is important when we see different compressing mechanism and where they are, and which nerve root they are compressing and in which level. I'm going to talk about the diagnosis and treatment of low back pain. This is one of the most common causes to visit your general practitioner. 84% of all adults will suffer back pain sometimes in their lives. Most of these episodes are temporary, and it is the leading cause of work-related injury in younger than 45 years old. Most of the physicians treating back pain are general practitioners and not orthopedic or surgeons. The risk factors for lower back pain are usually a young male in a very specific job that involves labor, dissatisfaction from that job, low income, smoking, and prolonged exposure to vibrations between 4 and 5 hertz, usually a jackhammer. L4, 5, and 5.1 make up roughly 90% of all disc herniations. There are many different pain generators for low back pain. It can be from the skin and subcutaneous tissues, from the joints, sacroiliac joints and capsule of the facet joint. It can be from ligaments such as longitudinal ligaments, interspinous ligaments, and ligamentum flavum. It can be periosteal. It can be dura, epidural tissue, annulus of the disc, which is innervated. It can be paravertebral muscles. All can be pain generators. Talking about the differential diagnosis of back and leg pain, we have to understand that the position of the spine gives us information about the cause of the pain. When flexing the spine makes the pain worse in the back, we usually talk about discogenic pain. When it makes the leg pain worse, it's usually because of a herniated disc. When extension makes the back pain worse, it's usually because of loading of the facet and spondylotic changes. When the leg pain is made worse, we usually talk about spinal stenosis. When we talk about referred pain in conjunction to facet joint pain, usually patients describe the pain as radiating to the buttocks, to the posterior hip, to the interface between the thoracic and lumbar spine. The map on the left helps delineate the different pain areas and the facet joint that is corresponding. The facet joints are innervated by the medial branch of the dorsal primary rami and the stenovertebral nerve, and that's why we get referred pain. It's connected to the dorsal root. That's why patients describe the pain, sometimes very close to radicular pain. But referred pain is usually deep, it's usually dull, it's usually aching. And radicular pain is usually more dermatomal in its distribution. It's usually more neuropathic, meaning going with numbness or electrical, and it usually goes below the knee. We're not going to go over the entire physical exam, just two pertinent issues. First is Waddell signs, which were first described by Waddell in 1980. And he described non-organic physical findings, such as tenderness to light touch, pain in a non-anatomic distribution, a loss of findings during distraction, or during different positions for the same provocative maneuver, like doing straight leg raise when the patient's supine and sitting. He also described overreaction or dramatization and pain on axial head loading. Some provocative tests, like straight leg raise, many different variations are described in the literature. Usually it evaluates the sciatic nerves, L4 to S1. It's maximum between 35 and 70 degrees, and it must radiate in a dermatomal distribution. A contralateral SLR is more specific, meaning it's correct sciatic nerve that is hurting when raising the other leg. A femoral stretch test usually checks the femoral nerve, L2, L3, sometimes L4. The pain should radiate to the anterior groin and thigh, going down to the medial. When we talk about imaging, imaging is usually not mandatory for 6 to 8 weeks unless there are red flags involved. Red flags usually refer to findings in the history that are corresponding to trauma, fractures, to infection, to malignancy. We talk about bladder and bowel incontinence, age, sometimes it says over 50, sometimes over 65, any trauma, any history of malignancy, weight loss, fever, constitutional symptoms, or of course IVDU. The first imaging modality for low back pain is an X-ray and not advanced imaging. When we do talk about advanced imaging, we have to remember that MRI has a high false positive, especially in advanced age. The graphs above were published by Bowden in 1990 in the JBJS. Shows that in asymptomatic, these are all asymptomatic subjects, there's a high percentage of abnormal discs, especially in the older population. When we talk about a discogenic back pain which is caused by the disc, we talk about sometimes it is called black disc disease, which notes the low intensity signal in T2 MRI. When we have a high intensity signal in the posterior annulus in the T2 MRI, we usually refer to an annular tear, which are different. The imaging, especially advanced imaging, must correlate to the clinical and physical exam findings because of these high false positive MRI findings. Adjunct imaging also exists, less commonly used. On the upper right, you can see the discogram or discograph, which is injecting contrast media inside the disc space. The upper one is a normal disc. You can see all the contrast stays inside the disc. The lower one, you can see that the contrast goes back to the canal, meaning that there is an annular tear. A CT myelogram is the same thing, injecting contrast media inside the spinal canal, and we can see how it distributes evenly unless there is a disc herniation or some compression. On the lower part, we see a SPECT CT, which is a CT superimposed with a bone scan, which helps us show signs of spondylolisthesis or infection or tumor. When we talk about Cauda Equina syndrome and Conus Medullaris syndrome, we're talking about compression, usually central compression, that causes neurological symptoms. Cauda refers to below the conus in the lumbar region, and conus is in the conus level L1, L2. Cauda Equina syndrome usually comes with severe low back pain, sciatica that is usually bilateral, saddle anesthesia, and usually motor weakness. We see loss or reduction of reflexes and varying degrees of bladder and rectal tone dysfunction. When we talk about Cauda Equina syndrome, although it's a relatively rare diagnosis, it is often missed. When we have suspicion of Cauda Equina syndrome, the gold standard route is to do an immediate MRI or CT and to have emergent or urgent surgery. Most studies show better outcomes when surgery is done below 48 hours. When we try and compare Conus medullaris and Cauda Equina syndrome, usually refers to the level, and different level of spine compression causes different symptoms. So the conus, which usually or typically ends at L1, we can see injury to the T12 L1 or T11 T12 areas. Usually it's isolated loss of bowel and bladder dysfunction. the cauda, which is injuring any lumbar level, it's usually due to a large herniated disc, can be some tumor or severe stenosis, and comes with some degree of motor loss of the lower extremity. So now we'll talk a bit about the surgical treatment for just low back pain. This is an issue that has been investigated and quite thoroughly. Here are the results for the Swedish lumbar spine study group, which in 2001 described their multicenter randomized controlled trial, tried to see whether or not surgical treatment for just low back pain got different or better results. And this is the 2-year results. You can see that after 2 years, there's still quite a difference between the surgical and non-surgical group. And we're talking about just back pain. We'll go on and talk a bit about disc herniation and radiculopathy. Some relevant basic science: 2 parts of the disc, annulus and central nucleus pulposus. The annulus fibrosus is a high collagen, low glycosaminoglycans. It is extensible and more tensile strength. It is mostly type 1 collagen, and it has nerve fibers, meaning it can hurt when it tears. The central nucleus pulposus has a high GAG level, low collagen. It is more compressible. It is the shock absorber, and it's mostly type 2 collagen. The aging disc has a lower water content, has a lower GAG, proteoglycan content, and a lower chondroitin sulfate content. It gets more collagen diameter, more keratin sulfate, and more non-collagen glycoproteins. This is a nice study that showed that why axial back pain gets worse when the internal disc pressure gets higher. So we can see that when we're sitting on a chair, leaning forward and holding something in our hands, we have the highest intradiscal pressure. When sitting on a chair and when leaning forward, holding something, we have higher intradiscal pressure. And that's why when we're lying flat and when the patient is flat, usually there should be no low back pain that is discogenic in origin. This is again to show that the posterolateral or parcentral disc herniation, which is the most common, affect the traversing and not the far lateral or the exiting nerve root. I'm talking about lumbar back pain and disc herniation. It's also important to mention MODIC changes. MODIC is Dr. MODIC, first described in 1988. They describe changes to the end plate in relation to this disease. They show 3 types of end plate change. The first is mirror inflammation or edema, which is shown as a low intensity signal in T1 and high intensity signal in T2, meaning high water content, edema. The second one is the fatty replacement, which is usually high both in T1 and T2. And the third is the sclerosis and microfracture, which is usually low both in T1 and T2. This can be causes of low back pain. The management of a disc herniation and radiculopathy is related to the natural history. And we know that 9% of patients with lumbar disc herniation and radiculopathy will get better within 1 month. We try for the first 4 to 6 weeks to do non-operative treatment, including activity modification, NSAIDs, bed rest, not more than 2 days, oral steroids, and we could try different injections. And of course, we have to mention judicious short-term narcotics and muscle relaxants. When we talk about operative treatments for lumbar disc herniation and radiculopathy, the literatures go way back. This is 1983, Dr. Weber in his study in volume 8 of Spine, and he described in his study 126 patients which were randomized to surgical and non-surgical treatment, he showed that an interior follow-up for these studies, the control trial group showed statistically significant better results for surgical treatment in a 1 year and also in a 4 year, which was not statistically significant, and there was no change between the groups in 10 years. The biggest and best study to date is by far the SPORT trial, which was a big multi-center randomized controlled trial for surgical and non-surgical treatment on different arms. This is one of the papers from this study, which showed the 8-year outcomes for lumbar disc herniation. What we can see is there's advantages for surgery in the intent to treat for the randomized cohort for all primary and secondary outcomes other than work status, return to work. We have to remember in the SPORT trial, there was a lot of shifting between arms, and 49% of patients assigned to non-operative treatment did receive surgery in the 8-year follow-up. When we do an as-treated analysis, we showed clinically meaningful results for the surgical treatment group for primary outcomes and non-primary outcomes. You can see this in the tables above. Now we're going to talk a bit about diagnosis and treatment of spinal stenosis. Spinal stenosis usually refers to two different entities. Usually when people say spinal stenosis, they refer to central spinal stenosis, which is the entity that can cause neurogenic claudication, heaviness, cramping of the cuffs, which we all know that sitting and flexion can relieve the symptom, the crossory card sign, and it's different from vascular claudication. The lateral stenosis usually causes more radicular symptoms, mostly nerve root symptoms in the lateral recess and then the neuroforamen. Here in the images, in the axials T2 of the MRI, you can see in L3-4 the far lateral disc, and you can also see the central stenosis. In the L4-5, we see mostly the central stenosis caused by disc herniation and bulging, and mostly facet hypertrophy and ligamentum flavum hypertrophy. When we talk about non-operative treatment, we should talk about education, about symptomatic treatment like activity modification, anti-inflammatories, physical therapy, and injections. Now we're going to talk about different injections. The two most commonly used injections are epidural spinal injections and selective nerve root blocks. The epidural is just put an epidural needle in the epidural space, and we see the epidural distribution of the contrast media. When we talk about selective nerve root block, a bit more technically demanding, it's about injecting the contrast and then injecting the anesthesia or steroids into the distribution of the nerve root. And we should see a nice distribution of the contrast media in a specific nerve root and cranial to it. When we talk about caudal injections is going in the caudal foramen from the bottom and getting distribution of the contrast and steroids above. Usually it goes up 2 or 3 levels. When talking about surgical management for spinal stenosis, we have to understand where the compression is and what's causing the compression. The above purple lines, they show us where the laminectomy is made. In taking out the laminas on both sides, we create decompression in the central canal, but it will not solve the foramen or neuroforaminal issues. In order to take the foramen and the nerve root which is exiting, we have to take out part of the facet or do a medial facetectomy. And in the purple circle, I try to show what a medial facetectomy is and where it lives. When do we do surgical treatment? When non-operative treatment has failed for over 6 to 12 weeks. We did earlier for Cauda, Conus, or progressive neurology. Decompression only is a good solution for spinal stenosis. We have to beware the pars, see that we leave enough pars so there won't be any instability issues. We do laminectomy for central stenosis, and we could do a medial facetectomy when there are lateral recess issues. The SPORT trial, the spinal stenosis arm, also published its 8-year follow-up, and it also showed that 70% of those randomized to surgery and 52% of those randomized to non-operative treatment had undergone surgery by 8 years. So there's a lot of movement between arms. When they did the as-treated analysis, they showed that early benefit of surgery out to 4 years. But then convergence of the curves, there's not a lot different in the 8-year follow-up. In contrast, the observational group, it showed a stable advantage for surgery in all outcomes between years 5 and 8. This is the observation groups. What about fusion? So we talked about decompression in the SPORT trial, but is fusion an option? Is it mandatory? We usually talk about fusion when talking about instability, when there's no more pars for some reason, when we've removed more than 50% of the facets, and where there's deformity and spondylolisthesis. We can see a good study, randomized control study by Forth et al., published in the New England Journal of Medicine in 2016. And they showed there's no difference between groups in a mean score of ODI in 2 years, and in the compression alone and in the fusion groups. Okay, let's talk a bit about diagnosis and treatment of the adult ischemic and degenerative spondy. The most commonly used classification for the etiology of the spondy is the Wilson-Newman. It shows us that spondy can be dysplastic or congenital. It can be isthmic. Isthmic meaning it can be a stress fracture of the pars. It can be an elongation of the pars, and it can be acute fracture of the pars. The spondy can also be degenerative. It can be traumatic, and it can be pathological or neoplastic thesis. The Meyerding classifications, right, for grades and spondylolisthesis at the end show us the amount of slip. It is of limited prognostication, but it's radiographic and simple to use. The epidemiology is there's for degenerative we have 5:6 to 1 female to male ratio. For isthmic it's mostly males 2 to 1. Degenerative is mostly above age 40. It's mostly older than that. L4-5 is most common. Isthmic is more developmental. L5-S1 is more common. Degenerative spondy is usually not graded than grade 1. Isthmic progression is more common, mostly in females and dysplastic. When we talk about imaging for spondy, we talk about oblique x-rays and the Scotty dog sign. I here tried to show a drawing, an x-ray, an oblique x-ray, to show what we talk about the isthmic. And here we see the L5-1. We can see the isthmic, the pars intervertebral that is fractured right in the neck of the dog. And in the 4-5, you can see how the pars is intact. When we talk about retrogenic spondy, usually we talk about removal of the pars. When we do a laminectomy, when we do a medial facetectomy, we take away too much of the pars and we cause it to break. Usually when we do a unilateral total facetectomy, we do more than 50% on both sides, partial facetectomy or medial facetectomy. That's when we have the highest likelihood of fracturing the pars or removing the pars by accident and having to do a fusion or fixation. Also, very important, the SPORT trial published its 4-year outcomes for the spondy group. We can see that the 44 years and the as-treated analysis, we see much better results for the surgical group. 50 points better for the bodily pain, 18 points for physical function, and 2014 for ODIs. And see that the difference is maintained over the course of the sport trial. When we talk about surgical treatment for spondies, we have to understand that when spine surgeons talk about fusion, fixation, arthrodesis, they talk about different things. When we say the word arthrodesis, we mean creating fusion mass. It doesn't necessarily mean using instrumentation. This is a study for degenerative spondy, prospective study by Dr. Herkowitz in 1991 in the JBJS. And he showed posterolateral or intertransverse process arthrodesis for degenerative spondy, a total of 50 patients. He showed excellent results in the arthrodesis group, less back pain, which were statistically significant, and better mean vertebral motion. This discussion about whether or not to instrument is not only a financial discussion, it's a discussion about the rate of pseudoarthrosis and whether or not instrumentation will enable me to get better outcomes, but also less pseudoarthrosis rates. And this same type of study was done by Fishgard and Herkowitz in 1997, which showed that the instrumentation group had a higher rate of successful arthrodesis, successful fusion, 83% compared to 18%, compared to 45% in the non-instrumentation group, and a higher rate of pseudoarthrosis, 55% versus 18% in the non-instrumented group. In the SPORT 4-year outcome published by Abdu in 2009, he asked whether or not fusion method matters. And they described taking PLF, which is posterolateral fusion, meaning putting bone between intertransverse processes, and doing a posterior instrumentation, which is PPS, or doing 360, meaning doing interbody work or fusion and doing instrumentation on the back. And he showed that he had solid fusion was achieved in 87% in the 360 group, 85% in the posterior instrumentation only group, and only 67% in the posterolateral fusion group. He had also higher pseudoarthrosis rates in the posterolateral group. And he concluded that, yes, fusion does matter and instrumentation does matter. When we talk about what type of fusion do we need and how many levels, usually for low-grade slip, grade 1 and 2, a fairly horizontal L5S1. Horizontal, meaning the sacral slope is relatively low. There will not be a lot of shear forces on our instrumentation, and shear forces are bad for spinal instrumentations. L5S1 only fusion usually is enough or sufficient. When we talk about high-grade slips, grade 3 and 4, and the L5S1 is usually more vertical in those, we like to fuse more levels for 1. This is just a general principle. And to conclude, I just want to show this. Today we have a lot of different approaches to the spine. Usually we distribute approaches relatively to the psoas. So we have our posterior to the psoas approaches, which is PLIF, posterior lumbar interbody fusion, going directly from the back, doing PLIF, transforaminal, meaning going from the foramen, from the facets. We have XLIF or lateral, far lateral interbody fusion going directly through the psoas. And we have anterior to the psoas approaches, which is OLIF and ALIF, anterior lumbar interbody fusion, going retroperitoneal. I suggest just reading or understanding every one of those and what it means. Thank you. Thank you very much. If you have any questions, feel free to text or call at my email or cell phone. Good luck.